Okay, good afternoon, everyone. Welcome. We are Waco AHEC, or the Area Health Education Center. We've got a couple of minutes just until we start. So for now, check in. I've left the chat open. Y'all should all be able to comment your little introduction if you want to let us know where you're from. We always love to see and hear it. Obviously, we're joined by our speaker currently, and like I said, we'll just start in a couple of minutes.
And then everybody's all quiet.
For sure. Okay, we're hitting that 1 p.m. start time, so we're going to go ahead and kick off into introductions. So once again, as a quick privacy check-in, this meeting is recorded and is also being live streamed. So anyone who's joining us from all around, hello. Thank you so much for joining us. We're happy to have you. Waco AHEC, or Area Health Education Center, is a center that is dedicated to making sure that health education pipeline programming is accessible to people in rural and underserved communities. Some of you are AHEC Scholars, so if you are, welcome. So glad to have you. As a reminder, you can receive 1 hour of didactic credit for attendance. So if you need verification for that, just go ahead and email me. I'll drop my email in the chat in just a moment, and we can go ahead and send you that information or verification. If you're not an AHEC Scholar, welcome. We always appreciate community members showing up and talking with us. Mix It Up as a whole is an interdisciplinary focus on making sure that y'all have the opportunity to put in and really explore subjects that you're interested in from professionals in a more casual and engaging setting. So what that means is we want you to ask questions. We have a bunch of questions that students have already submitted. We want to make sure that y'all have an opportunity to really get the most of what you want out of this experience. With that said, I'm going to go ahead and introduce our speaker. Dr. Kathileen Boozer is a full-time clinical practitioner and previously taught in undergraduate and graduate nursing programs at LHSON. Dr. Boozer graduated from Baylor University in 2003 with a degree in political science. She began her nursing career after graduating from West Texas A&M with her BSN in 2008. Dr. Boozer pursued her passion for nursing and serving others and became a family nurse practitioner in 2011. She completed a dermatology internship in 2014 and has been specializing her practice in dermatology and community health since that time. Dr. Boozer earned her doctorate of nursing practice from Creighton University in 2018. She is an active member of the American Academy of Nurse Practitioners, Dermatology Nurse Association, National Academy of Dermatology, Nurse Practitioners, Texas Nurse Practitioner Association, National League of Nurses, and Sigma Theta Tau. With all of that said, she is also a former board member for Waco AHEC, so we have worked with her in the past and we really super appreciate her. Kathy, go ahead and say hi to everyone.
Hi, everybody. Thank you so much for having me today. I really like talking about this subject, and I think it's funny because sometimes people are like, why is a skin specialist, a skin cancer specialist talking to us about opioid use and pain? Well, I will tell you, it hits everybody in every single profession, no matter what your expertise is. And so it is really important to have an understanding, but also look a little bit past what we think we know about it onto how we can really help each other and have open conversations about pain and what misuse and addiction really are and look like. So without further ado, I'll pull up my presentation. Okay, can you see it?
Yes, we can.
Awesome. Okay, so this is opioid addiction, a Texas-sized problem. I do not have any disclosures to give. I get nothing except for having this amazing conversation with y'all. So the objectives, we're going to discuss opioid addiction. We're going to analyze overdose in Texas, and we're going to review misuse and abuse of controlled substances. So prescription drug misuse and its consequences. So opioid analgesics, benzodiazepines, and other sedatives and tranquilizers, including stimulants too, have an important medical use, but they also stimulate the reward center of the brain. So in susceptible individuals, this can lead to misuse, substance use disorders, and other serious consequences. It has also led to the development and persistence of the illicit market for these medications. So despite government regulations on these medications, prescription drug misuse and its consequences persist. It's important to know the statistics that we're dealing with. So a little bit on our history. So this graph really shows data that was collected between 2013 to 2017 and was reported in 2019. So prescriptions for opioids represent over 45% of the total controlled medications that were dispensed across this entire period. So roughly 17.7 million opioid prescriptions were dispensed per year. So that's 63.7 opioid prescriptions per 100 persons. That's a lot. So it's slightly less than reported on the national average for Texas. Hydrocodone was the most widely prescribed opioid at 32.9%, followed by tramadol at 26.9%, and then codeine at 21.5%. The overall controlled substance prescribing rate appears to be decreasing, but this is misleading. So there is a reduction in the Schedule II medications such as hydrocodone and fentanyl, but there has been an increase in Schedule IV medications like tramadol. So at the same time, the total overdose fatalities increased 42% during this time. So even though the higher opioids prescriptions were declining, lower levels were increasing, but also fatalities were continuing to increase during this time. So when we look at the population adjusted rates, we had an increase of 34%. So almost 6 deaths per 100,000. So jumping ahead to 2019 to 2022, common opioids prescribed for pain include hydrocodone, tramadol, codeine, and oxycodone. Based on the preliminary data from 2021 and 2022 for unintentional drug poisonings related deaths in Texas, so we had a concurrent increase with the deaths with an increase of the use of opioid analgesics for pain. So when we're looking from 1990 to the mid 2010s, they were both associated with the mortality and morbidity. They rose just markedly. In a national survey among 63,000, among the 63,000 deaths in the US in a single year, approximately 42,000 of those deaths involved opioids. So why is this significant? Because we see opioid prescribing decreasing, but opioid-related overdose deaths are continuing to rise. And so we had approximately 68,000 in 2020. Of overdose deaths, including opioids, approximately 30% additionally involved a benzodiazepam. And so that increases the sleepiness So the sedating effect and the respiratory depression effect that opioids have. And so when you take a benzodiazepine with an opioid, you have an increased risk for overdose. So since 2014, overdose deaths among opioid analgesics increased to 516% among females and 300% among males. So the pathway from prescription opioid use disorder to heroin also has been increasingly recognized. So the Center for Disease Control and Prevention identified 3 waves of this overdose epidemic, and it was the prescription opioids, the increased use of heroin, and most recently, the ultra-potent illegal manufactured fentanyl. So when we're looking at this, it represents the number of ED visits for opioid poisoning for Texas residents. So when we're looking at ED visits, they're increasing, but in 2021, we had a little over 9,000 for opioids. And of those opioids, we had 425 for fentanyl. And so in Texas, over all ED visits, 3.4% were attributed to fentanyl. When we're looking at deaths, this graph shows us opioids, benzodiazepam, cocaine, prescribed opioids, heroin, psychostimulants, psychotropics, synthetic opioids, and fentanyl. And so when we're looking at the overall totality, I'm so sorry, I gotta take a drink. Of it, we're looking at also with the 5 major counties in Texas. So we have Harris County, which is in Houston. We have Dallas. We have Bexar. We have Tarrant, Travis. So we're looking at Austin, Fort Worth. When we're looking at all of these, we can see the counties that are most affected and the overall deaths that they had. When we break this down a little further, and so I'm gonna just call out Harris County since it was number 1. When we're looking at demographics, 405% were Caucasian, 252 Hispanic, and 280 were African American or Black. So when we are looking at drug poisonings related to deaths of commonly prescribed opioids, and we're looking at the same counties, we can see that in Harris County, we had 124. And when we break that up into the same demographics, we have 57, 33, and 33. When we add fentanyl into the mixture of drug poisoning related deaths for Harris County, we have 487 total. So 234 Caucasian, 125 Hispanic, and 119 African American or Black. And so these numbers and statistics are staggering and only rising. And you can see when they're all together, of course, they're going to have the highest one. But when you're looking at opioids, just by themselves, it's lower. But when we add fentanyl or we're adding other things to it, it also greatly attributes to the problem. And so how do we start to even tackle this? Well, it's important for us to educate ourselves and our patients on the inherent dangers that are associated with misuse and overdose, because a lot of times it's an accidental overdose that is occurring. So let's talk about misuse and abuse. When we are looking at defining misuse and abuse, misuse of controlled substances refers to using a prescribed drug in a way that it's not intended. It may be deliberate or accidental, but it has a negative result that typically will occur. Examples of misuse include taking too much of a drug, using an incorrect dose, using an incorrect route, using prescribed drugs written for another person, which is also becoming an increasing problem. So use disorder of a drug differs from abuse and misuse of a drug. So the drugs taken may be illicit street drugs, stolen drugs, or obtained via a legal prescription. Misusing a drug usually involves taking the drug in a harmful or detrimental way, resulting in personal, professional, or social problems. Unfortunately, the misuse of controlled substances resulting in mortality and morbidity is again, continuing to rise. It's pretty staggering. So according to the National Survey on Drug Use and Health, over 10 million people misuse prescription pain medications, and over 2 million misuse sedatives, stimulants, and tranquilizers each year. A common reason for the misuse is treating physical pain. Prescription opioid use disorder has been reported to affect about 1.8% of individuals 12 and over, more than twice as many as are affected by prescription tranquilizer or sedative use disorder, and more than 3 times as many as are affected by stimulant use disorder, which is about 0.5% of our population. When we're looking at misuse, estimates of prevalence of opioid misuse among patients who were diagnosed with opioid analgesics, they kind of widely vary. So the literature out there, depending on the population, who you're looking at, and the underlying disease, the misuse can range from like 12% to 78%. So when we are reflecting on the differences, how do we take this information from the studies and really apply it? So the National Survey for Drug Use and Health in the United States estimated that among approximately 76 million adults in the US who were prescribed opioid drugs in the prior year, 12% reported opioid misuse. So in this study that they did, 76 million people in the US were prescribed an opioid drug in the previous year. And when they looked at and asked the participants if they had a problem, 12% reported that they misused opioids. So when we compared the individuals who used prescribed opioids and did not report misuse, those reporting the misuse of the opioids reported higher rates of other substances together. So when we're looking at those who are reporting misuse, they had higher rates of additional substances that they also reported using, whether that was cannabis, heroin, benzodiazepine, or and they were also likely to also state that they were suffering from depression. And so that is also really something to think about. Other motives for prescription opioid misuse included that they needed to feel more relaxed, that they wanted to experiment, or they had difficulty with sleep. So prescription opioid misuse, the motives for it, other than pain, are associated with greater odds of benzodiazepine misuse or substance use disorder or suicidal ideation. And that's because we are having trouble sleeping, we are having trouble coping, we are experimenting with other drugs to help us get through the day. And so we have to look at pain and look at a person and what's going on in their life to put it together to really help us look at the whole picture. So how do we begin this conversation? Well, it's important to understand common terms that we look at when we're discussing addiction and risk for addiction. So even though these are similar, they are different. So addiction is the constant need for a drug despite knowing it has bad consequences. Pseudo addiction is this constant fear of being in pain. People are typically hypervigilant. And so when somebody's been on medication for a long time, there's a big fear of them going to be in pain. They're not going to be able to function. And so really overcoming those things is important. Dependence is this physical adaptation to the medication where it is necessary to function normally, and withdrawal occurs when they miss a dose or they lack a dose or when you try to wean them off. Tolerance is a lack of expected response to medication, so you're having to increase this dose to achieve the same pain relief. The American Society of Addiction Medicine really looks at addiction as a primary chronic disease of brain reward, motivation, memory, and related circuitry. So dysfunction in these circuits leads to characteristic biological, psychological, social, and spiritual manifestations. this is reflected in an individual pathologically pursuing this reward or relief by the substance use or through other behaviors. So like other chronic disease, use disorder often involves cycles of relapse and remission, but without treatment or engagement in recovery activities, use disorder is progressive and will result in disability and premature death. So in a systematic review, the incidence of opioid use disorder among patients who were prescribed opioids for chronic pain was estimated to be about 8 to 12%. 26% of patients within a large US health system who were prescribed long-term opioids met the criteria for DSM-4 opioid dependence in the last year. 19.7% of primary care patients prescribed long-term opioids met the criteria specifically for drug misuse. So using more conservative measures, if we look at the last 30 days, just a 30-day window, 3% of primary care patients prescribed opioids will have met the criteria for current opioid dependence. So the prevalence of opioid use disorder involving prescription opioids in the US general population markedly rose during the mid-1990s to the mid-2010s. It has since decreased a little bit. So that is good because we're becoming more aware of the problem. But the proportion of individuals seeking substance use disorder treatment who reported opioid prescription misuse, it increased from 1 to 9%. And so, but when we're looking at, even though there is a portion of the population who are getting help, when we're looking at 9% of our total population, looking at that 9%, 88% of these individuals were white. So we have a higher number, but the resources and the equity of those who are getting help is still very skewed. In 2019, 6.8% of individuals seeking substance use disorder treatment reported prescription opioids as the primary substance, compared with 23.4% for heroin. How are people getting the drug? So if we're prescribing less, but rates of death and misuse and other problems are rising, what's going on with this? So there's a variety of ways that individuals can get a prescription drug. So about 55% will get them from a friend or relative, 20% from a provider or prescriber, 10% purchased from a friend or a relative, 5% will be stolen, 5% purchased on the illicit market, 2% from multiple doctors doing doctor shopping, and 1% from theft from a medical practice or a pharmacy. And I will say this has happened to me. Someone stealing a prescription pad or calling something in under your name. So it's really important to know who you have in the office to working with you. So when we're looking at use disorder involving prescription drugs as a common problem, those affiliated may not necessarily fit the profile. And this is what is really important that I want to think about it. And that's why I threw in demographics earlier when we're looking at, in our mind, in our own internal biases, who we think of as maybe having a drug problem, what that looks like. But when we look at Texas, it affects all the major counties. And so for whatever reason that they are having a problem, you know, this is kind of the profile. So in the past 3 years of a US study, we looked at risk factors for non-medical use of sedatives or tranquilizers. So when we're looking at sedatives or tranquilizers for people using them, it's Caucasian, the white race, typically females, uninsured or unemployed, typically have anxiety or panic attacks, may have other psychiatric symptoms or history of depression, alcohol use, cigarette use, have a history of illicit drug use. So when you're looking at this and you're thinking, what does somebody who does sedatives or tranquilizers, they look like someone like me. Like I fit the looking at somebody walking in the office. Now, I'm not saying I have all this history because I don't, but that is somebody who you would think of, a female, older, 40s, 50s, coming in, complaining of sleep problems, has a history of depression, has a history of anxiety, those type of things. You know, I'm a lady from the 80s, so I'm really going to date myself here. But when I think of somebody who does heroin, who might be a drug addict coming in my office to get something, I might think of, you know, the band, the Red Hot Chili Peppers, or I'm going to think of the band Aerosmith, because that's who did heroin back in the day, but that's not necessarily the person that you get walking in there. When I think of somebody who does, you know, like weed or marijuana, I'm going to think of somebody who looks like Tupac or Snoop Dogg. And so I'm thinking of people that, you know, I grew up with, the music I looked at, but you don't always think of who does it look like when somebody has necessarily a pain disorder or who are drug seekers. Well, I will tell you, there are higher rates in the Caucasian than there are of Hispanic or African American Black individuals. And so when we also look at the ages, we have young higher overdoses in, you know, 12 to the mid 20s. And then we have our older geriatric patients, 65 and above, who have high rates of overdose of pain. And so you have to really step outside the box and say, this is an everybody problem. It is a problem that hits us all on every single specialty, no matter where we're at. And why is this important? Because in dermatology, we treat people with chronic disease all the time. Rheumatoid arthritis, lupus, psoriatic arthritis, all these things they're painful, right? And you have higher rates of skin cancers. And so when we have other chronic disease like vitiligo, pigmentation issues, it has a psychological burden too on people. And so I might see you in my office, but I can ask about how you're coping. I can ask about your depression. I can ask about how you're sleeping. I can talk to you about your social habits. Are you going out more? Are you drinking more? Are you coping other ways? So I actually might get more intel from somebody because they're not coming to me to treat their pain. So they might talk more openly about other habits or things that they're doing, right? And so we need those collaborative partner relationships, because what another provider might ask them, they may not be actually responding whole truthfully because of fear. We have this fear of being open and honest. So when we actually overhit that kind of crossing point or we're at risk, we're kind of trying to do it by ourselves because we live in this society where we have to do more, we have to be better. And so we're always pushing ourselves to that next step, but at what cost are we doing it? And so really this is an everybody problem, and we should all be looking at it, trying to help everybody see it and get the appropriate care. If COVID taught us anything, it's really that you never know what's going on behind closed doors. And with providers, you know, the burden that we take on, we have got to be open and honest because, you know, people coming in and leaving this profession are higher. And we have got to learn how to support one another and openly have these conversations. We also need to not be scared to have these conversations, because that's another thing we really find is we don't want to offend somebody. We don't want to ask them questions. So even if we're suspicious, if a lot of times we're like, that's not my problem. I'm not treating them for pain, so I don't need to ask them the questions. I'm not treating them for depression. I don't need to ask the questions. But how much damage are we doing by pretending like it doesn't exist, by sugarcoating over it? And so we have this thing called the PMP. And so anytime that we give a controlled medication, we have to look it up in the system so we can see how many prescriptions they have gotten, when's the last time they filled them, who gave it to them, what other types of medications that they're on that fall under controlled substances. So I give this example. I might have a patient who is going to a pain doctor, and so I know that they're getting prescription opioid for their pain, but then I might have that same patient who's going to a psychiatric doctor, and I just noticed that, you know, they just got a new benzodiazepine, they're having trouble sleeping, and so, you know, they just need to know the risk associated with both. But then they went to their primary care and, you know, they got another medication for I don't know, maybe they were in a car wreck and they got a new, you know, had muscle relaxer. But you put these things together, and then we have to really look at, somebody's got to say, what's going on? Are you coping by using these medications in another way? Are you seeking help? Are you meeting that point where you are getting tipped over the edge and it is turning into a problem? And that's when fear overcomes, because we can still treat pain, we can still treat all these things, but without leading to addiction. Because what happens is once it gets called, if you don't have that support underneath, you know, people find that all these things are taken away, and that underlying fear is when you start going for illicit drugs and going on higher drugs because they need to control it. But it's more than just a physical aspect. There is, you know, I always call it the tri. You know, we have our body, mind, and our spirit. And so really coming together, thinking about a person holistically and seeing them and helping them in the other ways that they need can change really everything. And so when you see a problem and you're looking at stuff, don't just ignore it. Talk about it. Ask them, empathize with them, or sympathize, you know, help them look for things that are going on, journal, and really have those open conversations, because that's really the only way that we can get better and we can change. So we're to avoid severe consequences of addiction and death, you know, we have to have these well thought out plans of how we're going to respond to prescription drug misuse and abuse. And so an approach that is communicated with patients has got to be a part of our treatment agreement whenever possible. You know, we need to standardize how we are doing things across practice. So it needs to improve with our use of time, our efficiency, and it needs to be fair to everybody. We can't just assume that somebody's going to look like, you know, C from Aerosmith, and that's who's going to walk in with a problem. So anybody who doesn't act like that is not, right? Or we have to assume that everybody, young, old, whatever, chronic illness affects every single specialty. I can't think of a single specialty that chronic illness does not touch. I can't think of a single specialty where depression and anxiety is not becoming a pretty common occurrence. Every single person. So if you think that that's not me, it is you. It is going to be you in the future. Even, you know, if you're physical therapy, speech therapy, all these things, people struggle, and we've got to be open and honest and really not be afraid to talk about these things out loud, but also not be afraid to help people and get them the help that they need, and building these strategic relationships to get them where they need to go. And so when we are looking at prescription drug misuse, it occurs across a spectrum when we're looking at risk. And so we have lower risk behaviors, a single episode of a patient taking an extra dose because of severe pain, to higher risk behaviors, regular non-prescribed use of medications. So the first response to misuse behavior should always be a discussion, non-judgmental way to assess the substance use disorder and overdose risk. It's always about risk versus benefit. If the risk is low and the benefit to the patient is high, move forward. If the risk is high but the benefit is low, you should be thinking, what else can I do? What else needs to occur? And so if somebody does have a history of abuse, it's a slow taper, very, very slow. Abruptly discontinuing the medication can have very negative consequences, but it's about treating the whole person and getting them the long-term help that they need. Where are my references?
Thank you so much, Kathy. That was like very, very kind of keyed in a lot to that human element. I really enjoyed that last kind of rejoinder to tell people to really reflect and think about what that looks like in their own lives. To that effect, our first question is one that was submitted online prior to this event, and I think it really fits in well with kind of the end of your presentation there. So the question is, how did COVID-19 affect all of these issues, and did it go ahead and lead to more, sorry, I'm not reading this correctly. And did it go ahead and lead into more issues and more substance abuse in general?
Well, I would say through COVID-19 as a provider for me. So let me back up just a little bit. So in the 2010s, what we really saw was all of a sudden we were recognizing opioids as a problem after it had been the fifth vital sign for so long. And so we were treating people's pain. And now we were seeing kind of the consequences of it. And then we had a lot of regulation come in right away. So we had all of these patients, and I worked in rural health at the time, that had been on long-term opioids for legitimate chronic pain. All of a sudden it was like, you cannot treat the pain anymore. You can only give them so much medication. And so we had all these people who all of a sudden didn't have help anymore. And pain wasn't really a specialty at the time. And so we were just getting to the point where we're overcoming that type of a thing and getting help and having the stepwise fashion to now COVID hit, can't go see anybody. And so at the time, telemedicine was very rare, and now it is becoming better. So what we saw was we had this lack of access for a little bit, then we had access to it, but what became available during COVID? Alcohol could get delivered. Alcohol, you could go pick it up. People were home, they were drinking a whole lot more. And so now you have this extra mix into it. You also had a higher unemployment rate. We had a higher isolation, more depression, more anxiety that came in with COVID. So when you mix alcohol and you mix depression, you mix not being able to get out in the fresh air or do anything, so you are isolated, and you put pain into that, we have increased risk of misuse and abuse because we have additional things piling on top. And that's kind of how addiction starts, right? Like no one wakes up one day and says, I want to have an opioid addiction, or I want to seek, I don't even know where you start, but if you are desperate, you're going to seek, where can I go get medicine or whatever I need to help me deal or cope with it, right? And so we find that it's really a slow fade, right? Something happens in your life, you're isolated, you are looking around, you don't really have the structure or the resources or the support set up. So we do things that help us sleep, that help us get through the day. And alcohol is something that is readily available and that you'll see people. So we'll start with, I'm drinking with my friends on the weekend. And then, oh man, I had a really hard day today. I'm going to have a drink tonight. And then all of a sudden, you know, a year or two later, you're looking over your shoulder and you're drinking every day. And you might be drinking with your friends and you might be thinking that's fine. But what else is going on? You had a injury at work and you're not working as much as you can. You have financial things going on, right? Your relationships might be strained a little bit. So, you know, you're using these things to cope with it. And then when you add opioid or pain on top of it or chronic illness, all of a sudden you need it. You're wanting to go to the bar. You are needing it. Your one glass of wine or beer at nighttime has now turned into a 6-pack or a bottle more frequently. And so people really start noticing it when behaviors start changing. So you're late for work, you're frustrated a lot more, you have a short temper, not sleeping at night is a big one, insomnia. And so then people start noticing those things, but as long as you're getting by, you continue to work through it. And so this misuse can go on for a while, but when it hits the addiction or the abuse, that's when you find that your life kind of falls apart. And without the setup or the structure, you know, you hit rock bottom. And then, you know, that's when a lot of times medicine, people get really afraid because they don't want to tell the truth because they're afraid that they're not going to get the help. And when we see the statistics of who's actually getting the help at that point, 88% were Caucasian people. So either one, they had the means and the resources to get help for addiction, or somebody asked them like what's going on and they had the addiction and were able to get those. But when we're looking at it, that's really 50% of our population who's in that category. And so if that's almost 90% of who's getting the resources, we are missing a huge population of people that are needing help. And so when you look at who has a problem, it is literally everybody. You can't think of it as a categorical, this is who it is. It's literally everybody who walks into the office is at risk for abuse or misuse. And so I have it on all of my questionnaires, and sometimes people just glance over it, but sometimes people give it a second thought. And I really make it a point to, even if it's just for 5 minutes, when I see patients and they come in to the office and they're sitting down, how are you? Not what's going on with your illness, what's going on with your skin, anything new. I want to have a conversation with how are you? And when you take time, even just a little bit, you find a whole lot of stuff that's going on. And if I find that things are, in just general life are chaotic, or they're changing, or new stressors, I can say, hey, how are you coping with it? Hey, are you seeing somebody for counseling? Do you feel like you're depressed? And a lot of times it's stigma, like depending on who I'm talking to, people don't want to let people know that they're depressed. But I'm like, if you can look over your shoulder, and there was a time not so long ago when you felt like you felt better, or you were able to cope with it better, you didn't want to snap somebody's head off, or you didn't want to sleep all day, like what is going on with you? If that is something like that, I'm like, there's nothing wrong with serotonin to put back to help you cope with it better while you're talking to somebody about it. There's nothing more rewarding than having a place to go. And I always call it verbal diarrhea, that where you can tell and just spill what's ever on your mind, whether it's a big deal or not a big deal, but somebody's listening, that you don't have to worry about if they're going to judge you. You don't have to worry about if they've heard it before and they don't want to listen, but you just are able to just get whatever off your chest. That is very freeing. And if you're going to take something for diabetes or for blood pressure, why wouldn't you take something that helps you cope with and deal with it, that is natural to your body? So I think sometimes just having conversations with people about that type of thing is helpful, but we have to come out and have those conversations, and we have to ask people about drinking, because it's huge. I mean, it is a big problem, and we just kind of ignore it and we think it's not my problem.
Yeah. So follow-up question on that. if a person who is coming in and definitely flags when they're talking to their provider, hey, I only drink socially, I only drink casually, but you're kind of putting together the pieces and you're seeing a little bit more of a disturbing or more difficult pattern emerging. How do you start that conversation of saying, let's really talk about your alcohol use? I also know that in some different cultures and backgrounds, it's more normalized to just drink more. So how do you kind of handle that conversation?
That's a great one because I think it became more normal, especially during COVID, to be like, oh, I have a glass of wine every night or a beer every night, when before it was like a weekend thing. And so I think it's really important when we're talking about alcohol to really talk about what else is going on. Because sometimes you might just be going out with friends, but is it like your two best friends that y'all all increase drinking together and y'all are all talking about stuff? Are you drinking more than your friends? I think sometimes when we're talking about our use, you need to put it in a big perspective. So just because somebody's drinking 3 times a week doesn't necessarily mean that they have a problem, right? They could be at higher risk for it. Now, if they're drinking and you're not putting them on medications that are problematic or could interfere, I mean, you just want to ask if they're just, like what else is going on with their life? I don't know how else to say that. But when you are prescribing medications and they do have a lifestyle like that, well, you have to think about risk versus benefit. Is it still a benefit to them versus the risk? And have those open conversations about what can occur. And then you ask them, are you drinking more over the last, and this is one of the things we have those questionnaires that you have, and it's always like, in the last 2 weeks, are you more depressed than normal? No, depression stayed the same. It's not better, it's not worse, or it has gotten worse. But I always think they're funny about the 2 weeks because no one really thinks about, I don't think about depression in a short term type of a 2 week type of scenario. So I really ask, hey, in the last 6 months, have you increased your drinking? Is it the same? Is the 6 pack going the same amount that it used to? How many are you buying? And I really think that people really start thinking about it when you're like, how much are you spending on your alcohol intake? I think that will make them take a step back sometimes. And really I approach it as, I'm not judging you for your alcohol intake. What I'm concerned about is the consequences that can occur if I'm going to prescribe you this medicine. Is it going to help you or is it going to make it worse? And what else do we need to look at? Because if you're using this as a coping mechanism for life, the medicine I'm going to put you on is not going to make that better. It's going to make it the challenge worse while you're dealing with it. So you have to bring in these other support systems to help. And I will say, I'll relate this to skin too. So, with psoriasis, and I shake everybody's hand when they walk in the office and I hug them when they leave. And, you'll have people that will cry when you hug them because no one has touched them for years because they think that they are, I don't know, contagious or something like that. And so I think people are hurting on different levels and they're actually willing to express out loud, and having that conversation of what's going on with you and what has changed and how are you doing, is where you start. And then people are more willing to talk about intake or alcohol, or are they, and you'll get this because people are like, they, with vaping and smoking and, marijuana is illegal in Texas, but you ask questions and, you can find out if they used gummies or all these other methods of getting, THC. But it's important to ask the how, and then you'll get to the what. What are they doing? Why are they doing it? But how are they doing changes the conversation and the honesty.
Yeah, reframing it as asking the question of how much is beer spending on it, that's really good. That's a really good hack. I know a lot of people are really going to enjoy that. Um, so our next question is what, in your opinion, has led to the disparities that we're seeing more women coming in as that picture of the typical pain use and substance use seeker?
Honestly, I don't know why it is higher with women. I guess if I had to just take a guess on it, I would say that if we generally think about pain and who is treating with pain, we would think about more men. Men have harder outdoor jobs, lifting heavier equipment, and now women have moved into some of those job type of things. I think so. You have just the physical aspect of long-term wear and tear that occurs on our bodies, and seeking treatment for those type of things. I think that sometimes people get treated for a while before we realize that there's a problem. And so I think women are just like anybody else we can hide a lot of things, right? I think when we step out, I don't know how to say this, for a long time, it's like we can say that we have pain and it's just like, but that's normal for you. So whether it's childbirth or, you're struggling with depression, I think for a long time we were looked at and it was just like, but you should. And they were just like, well, that's a woman thing. And so you fight these things and you move forward. But now that you are getting treated, I think there was a tipping point of doing stuff yourself, boom, treating too much, and then it becomes a problem. And I also think that people don't always suspect that women are going to have a problem. If I came in and I said I was having trouble sleeping, I'm a nurse, I'm an educator, I'm a mom, I just need to get through this time, I'm taking care of my parents. It's easy, I think, to give a script without stopping back and saying, ooh, do they have a problem? Are they seeking? And I think our ability, especially with the PMP system, to look and see for shopping or doing stuff, is good. And so I think there are a lot of stereotypes that we take in and what we think people should look like or be, and you really can't do that. So I think that it rose up a lot.
Yeah. That makes a lot of sense. Our kind of last wrap-up question is, as someone who is primarily in the field of nursing and is also an educator, what do you want to see on this topic for people outside of the field of nursing? Your social workers, your public health specialists, your policy people. What do you want to see from them to support you in your capacity as a nurse?
That's interesting. I don't really think there's anything I would do for me per se as a nurse. I think for healthcare in general, what I would like to see are more providers, more just more people stepping up and saying it's a we thing. It's not a you thing. I think when somebody comes in and they have pain and it's been longer than 30 days, it's really easy for us to say, you're going to go to pain. And then we ship them off to pain and we pretend like nothing's going on. And as long as pain's treating them, we don't talk about it. We don't ask questions. We just treat whatever they're coming in for. We have become so focused on that. What are you coming in for and how can I treat that? Because we're so limited on time that we don't always look at the whole person. And so so many times we have these moments that we are able to catch something and we're just like, not my problem, and we look away from it. But chronic disease have higher rates of pain, higher rates of psychological things that come with it. And so we all see that, and we all need to be on the forefront, not afraid to ask the patient what's going on with them. We have got to be like, I see you're drinking more. I see this is going on. Like, what is going on with you and how can I help you, instead of just writing somebody off. When somebody has a history of addiction and they legitimately have a new pain, something coming on, we can't just write them off. We have got to get them help, because if no one is going to stand up and help that person, they are going to seek something for that pain in a way that is not beneficial to them. So all that work that they did is going to go away. So we have to be able to look at ourselves and others and just say, how can we help one another? And each profession needs to be looking at it and not just saying, well, I'm physical therapy, you know, as long as they're bending, they're fine. I'm not thinking about these things. And so I think sometimes I spoke at the Texas Pain Society this year, and, you know, everybody was like, why did you come today? And I'm like, because it's important for all of us to talk about these things and know what's available to our patients. And when we stand up as another profession with a different perspective, it brings collaboration to a whole new level. And we have got to be able to collaborate. And I think that is something that I would like to see more of. I would like to see different professions coming together and having these conversations. What does our community look like? What are we missing? What do we need? How can we help people before it's a problem? And when it is a problem, what can we do? And I think when people have support and they have resource, it's a lot easy for us to make change versus when we're on our own, fighting on our own. You kind of stay on that side. And so that's what I would say we need as a community.
That's amazing. I'm actually going to slip one more question in under the line, because this is a question that all of our scholars ask every single presenter every time. So we've just kind of put it in as a permanent question. You have a very interesting background. You started in political science, and then you ended up in a completely different field. How has that change and that journey made you a better practitioner?
That is a great question. So I will say I was a freshman and my husband was a senior when we met, and I got married my junior year at Baylor. I found out I was pregnant the day after I got my letter to law school. So I will tell you, and that's the thing, I'm like, man, people forget to tell you that antibiotics like interfere with medications like birth control, right? So it's like 2 months later, you're like, I'm still taking that pill. But so I worked in finance for 3 years, and I was like, man, my LSAT's going to run out. I'm going to reapply to law school. And my mother was just like, I don't think that's a great idea. You want to be a mom, but you want to make a difference. And so she's like, why don't you go nursing? And I looked at her and I was like, woman, I do not do blood and I do not do sick people. I was like, that is a horrible idea. But I only needed A and P. And so she's like, okay, my husband and my mother applied to nursing school and enrolled me in A&P. I took it that summer. And so I said, fine, I'll do 1 semester. If I hate it, I'm out. But if I like it, I'll stay. And I loved nursing school. I was like, how did I not discover this earlier? I love nursing. And what I also love about nursing is you're not limited to one thing. If you want to do peds, you can do peds. You can do ICU. You can do politics. You could do education. You can be see people at home. You can do cancer. The research. The sky is the limit on what you want to do. And so I worked in the neonatal ICU, and one of the neonatologists, Dr. Subani, who I think is amazing, sat me down one day and he said, Boozer, I think you need to pursue your nurse practitioner. He goes, I think you need to take it to the next step. And he wrote my letter. And so I was doing some lactation education with the moms. And so I was like, oh, I can't really focus just on the babies. I love the family. So I did my family nurse practitioner. My husband and I were super happy up in the Amarillo area, but we felt like we were being called back to Central Texas. So I took a job at Rural Health because that's what my heart and passion was. I saw a lot of women and children, and the closest derm was 2.5 hours away. And I applied for the internship because we were missing something that we needed. I mean, that year I even diagnosed a brand new leprosy case. I mean, we had so much stuff come in and we really needed the resources. And so when I went to California and finished my internship here, I wanted to bring that expertise back. to rural health. My oldest at the time was diagnosed with dyslexia, so we moved to the Waco area, but I went out to Coryell County and did dermatology in the family practice setting. And then when I got into grad school, the only reason why I left was because I needed to follow the experts who skin cancer was really my area of focus, specifically melanoma. So to be around surgeons and to follow them, I went to private practice for that year to get the training that I needed in that particular area. And then I went into academia after that because I can only touch so many lives by myself in my practice. But when you teach the next generation to pursue greatness beyond themselves and that they are capable of loving other people and serving them and being healers, we can touch so many more lives. And so this is actually the first year I've taken a break since 2017 from academia and started my own practice here in the area. But I love it. It's always about being the best that you can be, but not for yourself, but for others. So every time I've taken a step forward, it was to pursue something to be able to serve people that need it. And that's why I focus on community health and rural health, because we get in these niches, but then there's always a need. Who's going to fill the gap in that need, to bring us together? And I always said, I am a Jesus loving, if my demographics mine would be Jesus loving Texas. Like that's just who I am. And in my practice, it is not my job to judge. You don't have to believe what I believe, and I'm not going to push my belief on you, but I am going to hug you. I'm going to ask you if you need prayer. I'm going to ask you how I can meet your needs in more ways than just what you came in for. Because that's important, I feel like, as people. And when we look at people, we should be doing what we can and bringing in aspects of community and resources that are available is just as important as the medications or the disease that we're treating. And so you have to look at people holistically and needs holistically. And I think change starts with just stepping forward and saying that I'll do it. And so that's me. I'm like the yes person. I will do it. Send me. And that's kind of how my career has gone and how I've grown.
That's amazing. Yeah.
That's the best, but I always pursue the goal.
That's amazing. Having that kind of mission-oriented focus is definitely so valuable within healthcare. And filling the need is something definitely that we need. But yeah, thank you so much for doing this presentation. To everybody who is attending right now, thank you so much for coming. For everybody who is watching the live stream, thanks to you too, and to everyone who submitted questions and who are watching this later, thank you so much as well. Please feel free to reach out to us if you have any questions, and we'll be sending you a follow-up email with a survey and the links to other Mix It Ups. Next month in February, it is going to be human sexuality with another current AHEC board member. So once again, Kathy, thank you so much. This was an amazing presentation. And everybody have a wonderful day.